Hello and welcome to my channel. In this channel, we explain various nursing concepts in a simple form for a better and easy understanding. These videos could be used by both LPN and RN students as well as nurses who are trying to refresh their basic concepts. My name is Nasmosh. In this video, we're going to start talking about the neurological disorders, and more precise in this video, we're going to talk about head injuries, hypothermia, as well as ICP, which is intracranial pressure. So head injuries. What is a head injury? A head injury is any trauma that leads to injury of the scalp, skull, as well as the brain. There are three types of brain injury that we need to know, which include closed head injury, basal skull fracture, and hematomas. So closed head injury is when the head sustains a blunt force trauma, and it could be three various types, which are concussion, contusion, and diffuse axonal injury. So with concussion, this involves temporary loss of neurological function with no apparent structural damage, right? No structure damage. With a contusion, there's a brain damage, and it's characterized by loss of consciousness as well as confusion. Diffuse axonal injury is where there is shearing and rotational force producing brain damage. So basal skull fracture. A basal skull fracture signs and symptoms include bleeding from both the nose and the ears. There will be CSF from both ears or the nose, and the way to differentiate between CSF and mucus, we always CSF check. How do you do this? We assess for glucose because CSF is high in glucose, and also we check for the halo sign, which is like a yellow ring which forms when you dip something white like a tissue into CSF fluid. And sometimes the patient could report tasting like sweet because it's high in glucose. The patient will also have raccoon eyes, which is periotobial edema and ecchymosis. When we say raccoon eyes, you see raccoons, they have a white face, and where the eyes is black, right? So that patient will have blackness, ecchymosis around that, the periorbital area. And the Basal sign, which is postocular ecchymosis, ocular, the ear. You'll see the ecchymosis, the staining on the ear, and it's noted on the mastoid bone. Lastly, let's talk about hematomas. So there's two types of hematomas. There's epidural hematoma and subdural hematoma. With epidural hematoma, this is where bleeding is occurring into the space between the skull and the dura, and it commonly involves the middle meningeal artery. So it's the artery bleeding. The typical signs and symptoms of this: the client sustains the injury. The injury is followed by a brief loss of consciousness. Then it's followed by a lucid interval, then rapid deterioration. So the patient will get the injury, they'll lose consciousness, they'll become lucid again, they'll become aware again, and then they start deteriorating. So emergency treatment for this will do burr holes, like drilling a hole, and placement of drains to relieve the intracranial pressure, right? Because we are bleeding into this space. Remember, the skull is not expandable. It's fixed space. And the more these bleed, the pressure is going towards the brain because that is the spongy substance. So that's what is being pressed on, and if there is more damage to it, we can reverse the damage. So subdural hematomas. So with subdural hematomas, there is bleeding below the dura, and this one is usually venous. Remember, epidural is arterial, subdural is venous. Arteries, oxygen. Venous, carbon dioxide they carry. So with subdural hematomas, it could be categorized as either acute, subacute, or chronic. So signs and symptoms of this category. So with acute, this develops 24 hours and includes a change in level of consciousness and pupil changes as well as hemiparalysis. Subacute symptoms, they develop between 48 to 2 weeks after the injury, right? This is the kind of patient who walks out of the emergency room because they look okay, and then they could succumb or they get worse after they left because the bleeding is considered slow. And remember, with venous, we don't need carbon dioxide. We actually need it. It's a waste. So when you have an arterial bleeding, it will be noticed first because we will be losing that level of consciousness due to lack of oxygenated blood to the brain. And the chronic subdural hematoma, this is seen frequently with adult patients, elderly patients, and it mimics a CVA. And management for this is surgical. We need to evacuate the hematoma, and we could also bore holes and place drainage to decrease what? ICP. Our nursing considerations with patients with head injuries. We always assess the client frequently for signs and symptoms of increased intracranial pressure, because with increased pressure we will end up damaging that brain, and once we damage the brain, we're not getting the brain function back of the specific place we damaged. We prevent or minimize increased intracranial pressure. And how do we prevent this or minimize this? We instruct the patient not to bend from waist down, to avoid sneezing, straining. Like if they're going to school, to the bathroom, we are giving them stool softeners. With sneezing, coughing, those kind of things, we tell the patient that those kind of strains, they do increase intracranial pressure. We position this patient at a 30 degrees angle, like a sitting position, not 45, 30 degrees, just to be able to drain sufficiently from the brain. Aspiration precautions are always in place. We maintain homocapnia. Homocapnia is the normal blood CO2 level. Why do we maintain homocapnia? This is because CO2 stimulates breathing. We need carbon dioxide. Remember, with subdural hematomas, it's a venous bleed, and we are losing the carbon dioxide in the blood. And if the carbon dioxide is not at a certain level, then your brain is not going to tell your respiratory organs to breathe. So we need to maintain the CO2 levels that enables us to breathe. And the non-surgical interventions are considered unless there is 10 ml collection or if the patient is symptomatic. And we also monitor the patient for systolic blood pressure. So systolic blood pressure measures the active blood output, which is perfusion of the body. So we need to see that the patient is perfusing adequately. Our next neurological disorder will be ICP, which is increased intracranial pressure. And this is where there is an increase in pressure within the skull that can result from or cause a brain injury. Remember, the skull is solid, is not expanding. And when there is increased pressure, the pressure will tend to push the thing that can move. The skull can move. What will move the brain? So will cause the brain injury. What are some causes of ICP? This could include a head injury with a subdural or epidural hematoma, like we just spoke, cerebrovascular accident or cerebral edema, a CVA, brain tumors, hydrocephalus, ruptured aneurysm and subarachnoid hemorrhage, as well as meningitis and syphilitis. With hydrocephalus, this is children who the head becomes big because they're retaining that fluid in the head. What are the signs and symptoms of ICP? So signs and symptoms of ICP may vary on the cause and the location, and they will always affect the level of consciousness. So what are the early signs? The early signs are changes in level of consciousness like restlessness, confusion, drowsiness. They'll have lethargy or stupor, motor and sensory changes as well. So they will have irritability, they'll have nausea and vomiting, often projectile. They're just irritated, the body's irritated. The pupil will have changes, and this will include they'll be dilated, they'll be unequal, and they'll be non-reactive. Perler. Remember Perler. And also we're going to detect some changes with the patient's vital signs, which will include like ineffective thermoregulation, right? So they'll not be able to regulate their temperatures well, and they could end up with a Cushing tired, which is hypertension with a widening pulse and bradycardia and irregular breathing with chain strokes respirations, which will include the chain stroke respirations. What are the nursing care that we should always have in mind for this kind of patients? So nursing care for ICP patients include, we are all monitoring this vital signs and neurological functions, right? Because we are going to see different or increase certain vital signs. We need to monitor that. We're going to keep the head of the bed at a 30 to 45 degrees angle. We're going to keep the head at a neutral position to enhance drainage. Remember, we are keeping them still. We don't want moving, so we need this fluid to drain from the brain, the cranial. We need the cranial pressure to decrease. We're going to maintain maximum respiratory exchange, which is hypocapnia, which causes vasodilation and thus can increase ICP. Remember hypocapnia, we talked about the CO2 levels. We need it maintained so we are not hyperventilating, right? And then we need to administer oxygen to increase the oxygen supply in the brain. Because there's less perfusion, there will be less oxygenation. So we need to give this patient an increase in oxygen for effective perfusion. We'll monitor fluids and electrolyte, the fluids, the I and O. We may restrict fluids to prevent increased cerebral edema, right? I and O. How much are we giving the patient and how much is coming out? We'll administer, of course, medications as prescribed if it's diuretics or any kind of medication. We'll decrease environmental stimuli. We need the patient to be at rest. Increased stimuli, increase pressure into the brain. And intensive care is required to monitor ICP. When we are doing an ICP monitoring, the patient will be under intensive care. So some medications that we'll see with patients with ICP, they'll need to avoid opioid sedatives unless they're ventilated, because this will restrict the neurological assessment, right? Opioids, they make you sleepy. Sedatives, they kind of depress your respiratory, you're drowsy. We can know if you are awake and alert, if it's because of the medication or we are having a change of status, mental change of status. We're going to place barbiturates to place the patient in a therapeutic coma with ventilator support, and we close monitor cardiac status. We're going to give Talon acetaminophen for fevers. We're going to give them osmotic diuretics, as I told you. Mannitol is good at ICP, and also steroid to decrease that inflammation, right? Like the maxtrozone, and it's also used to decrease the cerebral edema, the inflammation. So hyperthermia. So hyperthermia involves elevated temperature and may be caused by what? Infection, damage to the hypothalamic temperature regulating center, and thus increasing cerebral oxygen demand, so that we are not regulating our temperature well. Some of the causes of this could be infection, as we said, cerebral edema, and environmental heat. Sunny days. Signs and symptoms include elevated temperature, shivering, and hypoxia. Nursing care that we need to do for these patients will assess neurological status as well as vital signs. We'll use a hypothermia blanket to cool a cooling sponge to cool them down, because remember their temperature is really high. We need to cool them down, but we need to cool them down slowly. We'll monitor the ECG, our cardio status for tachycardia and dysrhythmias compensation. We'll monitor for manifestations of dehydration by checking the INOs and weight daily, because the patient is hot. When you put anything liquid with heat, it evaporates. So just think about that, dehydration. We're going to initiate seizure precautions, and they may be prescribed benzodiazepines to suppress seizure activity. And what are seizure precautions? Seizure precautions are, we need to have like a suction machine next to the patient's bed. We need to have oxygen, padded railings, bed in the lowest position of it, clear the room so that whenever the patient goes into seizure, they're not hitting furniture. There's oxygen, there's suction. We have the rescue things next to them. And we also need to prevent the patient from shivering, which may occur if the temperature is reduced quickly, to decrease the risk of increased ICP and oxygen consumption. So remember, we need to cool them slowly, because if you cool them quickly, you're going to send them into shock. So cool them slowly, let them cool slowly, and if you see there's changes, you need to stop. And we normally give them benzodiazepams too during this to prevent the shivering as well. So that's it for this video. We'll continue in the next one. Thank you for watching. Please like, share, and subscribe to my channel. See you on the next one. Bye.